Hello, Miss Ruther and Miss Smith. This is my setup for doing my head-to-toe assessment. I hope it works for you. We're just going to go ahead and dive right into it. I have my equipment assembled. I've closed the door for privacy. I'm going to perform hand hygiene. I'm going to introduce myself to my client and ask him to tell me his name and his date of birth. So I've got my two identifiers. I know I've got the right client. I'm going to explain to him that we're doing a head-to-toe assessment and let him know that if he has any questions throughout the process, for him to please speak up and ask me. We'll start the assessment by evaluating his vital signs. We'll take his temperature. Normal finding will be between 97.7 and 98.8. We'll take his, or we'll observe his respirations. Normal finding would be between 12 and 20 breaths per minute. We'll take his pulse. A normal finding would be between 60 and 100 beats per minute. We will take his blood pressure. A normal finding would be a systolic blood pressure of between 95 and 140. And a diastolic of between 60 and 90. And then we'll take a pulse oximetry reading. A normal finding there would be between 95 and 100%. After we've done his vitals, we'll assess him for pain. We'll ask him to rate his pain on a scale of 1 to 10, 1 being less pain, 10 being more pain. Once we've got an assessment, or a rating, we'll use the Calder technique to assess the character, the onset, the location, the duration, any exacerbations, whether the pain radiates, whether he's able to get any relief from the pain by doing anything. So once we've assessed his pain, we'll move on to his level of consciousness. He's been able to speak to me, so I know he's alert and awake. I'll ask him what his name is, where he is, what time it is, what day it is, to assess that he is oriented to person, place, and time. And then I will make note of his mood, his affect, and his behavior. I would say something along the lines of his mood is appropriate for the situation. And he's calm and cooperative. That would be a normal finding. So once we've completed that part of the assessment, we'll move on to actually assessing his physical person. As we do this whole process, we will be assessing his integument for, and by assessing I mean inspecting and palpating for color, temperature, moisture, any edema, any lesions or growths, any wounds or drains, any IV sites, or any other invasive lines. We'll want to be checking those out. As well, he is fully clothed, and we will be doing our assessment outside of his clothing. In practice, we would be doing all of these assessments that require it under the clothing and not on top of it. Now that we've got that out of the way, we'll start with the head. So again, we will palpate, and we will inspect his skin, his hair, especially want to check the back of his head, behind his ears, the places that sometimes get missed for pressure ulcers. So once we've assessed his skin, we'll check his hair out. We'll make sure that it's evenly distributed, and make note of the color, any abnormalities. After we've assessed his skin and hair, we'll ask him if he uses any corrective lenses, if he's having any issues with his vision, either near or far. We'll assess his hearing. We'll ask him if he uses any hearing aid or if he's having any trouble hearing. After we assess his hearing and vision, we will move on to his nose, and we will inspect his nares, and then we will ask him to breathe in and out through his nose, and we will occlude a nair, ask him to breathe in and out, occlude the other nair, ask him to breathe in and out to make sure that both nairs are patent. Then we'll assess his mouth, his lips, his teeth, his tongue, his oral mucosa, again, noting any issues with color or moisture, any lesions or growths. After any missing teeth or any issues with his teeth. After we've done that, we'll ask him to open his mouth, push his tongue down to the bottom of his mouth and say ah. We'll be testing the 9th cranial nerve, that's the glossopharyngeal nerve. When he says ah, we will expect his palate to elevate evenly. We will not be assessing the 10th cranial nerve, the vagus nerve, by instigating a gag reflex. So after we've done that, we'll move back up to his eyes. We'll assess the external anatomy of his eyes, his eyelids, the distribution of the hair, again, the skin. We'll make sure that we'll evaluate the color, the shape, the size, and the symmetry of his eyes. After we've checked out that external part of his eye, we're going to test the 3rd, 4th, and 6th cranial nerves. That would be the oculomotor, the trochlear, and the abducens, by doing a test where we ask him to keep his head still and follow the pen in either an H or a star pattern. And so I'll demonstrate. Again, I might have done that a little bit further away from his face, but the normal finding would be that he can follow without moving his head the pen. Again, we would ask him to not move his head while we're doing that. So again, that's the 3rd, 4th, and 6th cranial nerves, the oculomotor, the trochlear, and the abducens, and that's testing his extraocular movement. So after we go on from that, we'll check his pupils, or his perla, P-E-R-R-L-A. That's that the pupils are even or equal, that they are round, that they're reactive to light, and that they can accommodate. This is the 3rd cranial nerve. We'll test this. Well, first we'll observe his eyes, make sure that the pupils are round, that they're equally sized. We'll take a measurement. It's like about 3 millimeters. And after we do that, we'll dim the lights to cause his pupils to dilate. We'll take the pen light and we'll introduce that light to his eyes to cause them to constrict. Normal finding would be that it's a brisk constriction and that it's even on both sides. To test for accommodation, we'll ask him to look at the pen, we'll bring it in towards his nose, and we would expect his eyes to converge. That would confirm accommodation. So that does our perla. Again, that's our 3rd cranial nerve, the oculomotor nerve. So after we have done those assessments, we'll move on to the neck. So again, inspecting the skin, palpating, and inspecting. We'll look for jugular vein distension. That's if his jugular vein protrudes away from the rest of the skin. That's an abnormal finding. After we've checked for jugular vein distension, we will palpate the carotid arteries on either side independently, gently. So as we palpate them, what we're assessing for is rate, rhythm, amplitude, and that they are equal on both sides. Again, we would expect 60 to 100 beats per minute, a steady rhythm, and that they are not weak or absent or bounding, but in that middle ground of 2+ regular pulse amplitude, again, on both sides. After we do that, we'll auscultate using the bell, the carotid arteries. And again, what we're expecting to hear is just a pulse sound or no sound. An adventitious sound would be a brewy or kind of a whooshing sound. So that completes the, oh no, still got to do one more cranial nerve. This is cranial nerve 11. The accessory nerve will ask him to shrug his shoulders against resistance, and turn his head towards his shoulder against resistance. Again, a normal finding would be that it's equally firm on both sides and he's able to produce that motion. So that would conclude our test of our examination of his neck. Again, that last test was for the 11th cranial nerve, the accessory nerve. So we'll move on to the upper extremities. We'll ask him to close his eyes. We'll touch him in a variety of spots on his upper extremities and ask him to identify where those are, notifying that he has sensation. After we do that, again, we'll assess his integument for all the things that we mentioned at the beginning, especially with the arms, probable if there are any IVs or lines that they would be there. So as we're doing that assessment, we'll check the nails, and while we're checking the nails, we'll give them a little squeeze to blanch them and then check for capillary refill. They should return to that pink color within 3 seconds. So we've assessed his integument, inspected and palpated. We've checked his capillary refill. Then we're going to do a radial pulse check. That is right in this area right here. We'll check them both at the same time. Rate, rhythm, amplitude, and that they are equal, just like the jugular veins, 60 to 100 beats per minute, a steady rhythm, and that they are not bounding or weak, but they're that 2+. So from there, we would ask him to do range of motion exercises. I would ask him to follow me in range of motion exercises, something along this line that test or that show that he has range of motion shoulder, elbow, and wrist. Again, we would do that on both sides. So then we do a strength test. We'd ask him to squeeze our fingers, our index and our middle finger, with both hands at the same time. Again, we would expect a firm and equal grasp there. So that concludes the upper extremity. So then we'll move on to the chest again. There would be no shirt on here. We'll start by inspecting the skin, front and back. We'll palpate. Again, front and back. Again, we're looking for masses, lesions, inspecting the skin integrity and looking for any abnormalities. After we have done the palpation and the inspection of his skin, we'll evaluate his AP diameter and ratio. We would expect that to be between, or his chest to be twice as wide as it is deep. Then we'll assess his breathing for a minute. We would expect 12 respirations per minute, and again, rate, rhythm, and depth. So we would see if he's having any kind of labored breathing. Again, we would expect those 12 to 20 breaths per minute, and for the rhythm to be regular. So after we've done that assessment, we'll listen to his lung sounds in a pattern that touches on all 5 lobes. So we'll ask him to breathe in and out through his mouth as we do this. Making sure that we get the sides. We'll do the same thing on the back. Asking him to breathe in and out. So normal breath sounds would be clear. Adventitious breath sounds would be crackling, wheezing, rhonchi, or any diminished sounds in the different areas of the lungs. Again, I would use the diaphragm to auscultate his lungs. So after we have done that assessment, we'll move on to his heart. So, and the mitral point, midclavicular fifth intercostal space, will palpate the point of maximal impulse, and we will palpate that for rate, rhythm, and amplitude. Once we've palpated, we will listen to the heart sounds. I wouldn't be talking as I do this, but so we'll listen to the aortic at the second intercostal space. At the sternal border, we would expect the S2 to be louder than the S1. Then we'll move to the pulmonic. Again, the second space on the left side, the aortic being on the right. Then we'll move on. Again, we would expect S2 to be louder than S1 on both of these points. We would move down one intercostal space to the third intercostal space along the sternal border. For the Erb's point, we would expect S1 and S2 to be equal. We'll move down one more to the tricuspid spot, and in that spot we would expect S1 to be greater than S2. Then we'll move back to mitral, fifth intercostal space, midclavicular line. We would expect S1 to be greater than S2. We will listen for a full minute there, again, for rate and rhythm. Expected findings would be 60 to 100 beats per minute and a regular rhythm. So after we have done the cardiac assessment, we'll move on to the abdomen. Again, we'll assess the contour by inspection. We'll check the skin. We'll do our normal skin assessment, hitting on all those points. We'll ask the client if when he had his last bowel movement, if he's having any urinary incontinence or any other urinary issues. After we inspect and we ask those questions, we'll go on to auscultating first before we palpate for bowel sounds in all four quadrants. We'll listen for a full minute in each quadrant, and we would expect normal sounds to be between 5 and 30 sounds per minute. If we don't hear any bowel sounds within the first minute, then we'll listen for an additional minute. From there, we'll go on to palpate his abdomen. We'll ask the client to let us know if he has any pain when we're doing this. We're palpating for softness, tenderness, and for any masses. Again, we're going to do all four quadrants in the same pattern that we did before. So after we have done that, we've completed the abdominal assessment. We'll move on to the lower extremities. Again, we'll do the integumentary assessment just like we've done for the rest of the body, especially looking at the buttocks and the bony prominences to make sure that we're not seeing any skin breakdown. As we're doing the integumentary assessment, we'll check the nails. We'll check for capillary refill again. Same expectation as a 3-second refill, and that it's equal on both sides. We'll check pulses. The posterior tibial is right behind the malleolus, and maybe a little bit below. The dorsal would be on the top of the foot in the first intertarsal space. We would again inspect those for rate, rhythm, amplitude, and whether they are equal. Same findings, 60 to 100 beats per minute, regular rhythm, and that 2+ amplitude. We will inspect. We'd ask him to close his eyes, and we will touch in several places to inspect for sensation. We'll do range of motion exercises to show range of motion in the hip, the knee, and the ankle. We'll do strength testing by having him do the gas pedal technique where he would push and then pull back with his foot. We would do that bilaterally, and again, we would expect to be equal strength on both sides. And that would complete the assessment from head to toe. Again, with the integument, throughout the process, we are looking for temperature, color, moisture, edema, any lesions or growths, any wounds or drains, any IVs or other invasive lines, and we will assess those as we go out throughout the whole body. We're going to want to inspect him from head to toe, front to back. We would then do a Braden scale assessment. If he was between 23 and 19 points, he would not have any risk of skin breakdown. If he was between 15 and 19, he would have a low risk. If he was between 12 and 15, he would have a moderate risk. If he was between 9 and 12, he would have a high risk. And if he was below 9, he would have a very high risk of skin breakdown or a pressure ulcer. I would document my findings. I would wash my hands. I would make sure that the client is taken care of, and I would leave the room. Thank you.